Wait a second. Yeah, I can see you've got another joke. You should yours. I have to do all new now.
Are we ready? Okay, so welcome.
Thank you.
Thank you all for being here tonight on this beautiful day that was, we got a chance to go outside. It was a really nice day, so thank you for being here tonight. My name is Judy Postmus. I am the dean here at the School of Social Work at the University of Maryland in Baltimore. And I'm so pleased to welcome you in person and the 61 people online to the 28th Daniel Thurs Social Justice Lecture. So welcome to alumni, faculty, staff, students, particularly, and DAG, who's taking pictures and making a lot of noise. Particularly want to welcome members of our broader community who are here, as we believe so firmly in being partners with our community here in Baltimore and in Maryland. So thank you for being here today. And again, welcome to those of you joining us remotely. So I'm particularly pleased to celebrate tonight's event, Thursday Lecture, which is on anti-racist approaches to drug decriminalization, thinking beyond public health. This event is co-sponsored by the leaders of A Beautiful Struggle and the Community Justice and Equity Initiative, which was started by our own Dr. Corey Shtema. This event will shed light on how public health, using a public health lens, has pathologized our Black communities. The panel will be discussing alternative views on drug decriminalization. And in case you didn't know, the Daniel Thurs Social Justice Lecture Series is an integral part of the commitment to addressing social justice issues. Dean Thurs was a social work scholar, leader, activist, and dean here at the school. And his lecture series honors his vision of collaborative partnerships and service. His family, colleagues, and friends established the endowed professorship and lecture series to honor his example and his vision. And I'm honored to know, I believe, is Alex here? Maybe remote?
I think remote.
Any Thurs family members who are joining us remotely would love to thank you for being here and appreciate you all joining us. This event is being hosted by Dr. Corey Shtema, who is our Thurs professor in the Thurs professorship. As befitting her professional background, Corey is a scholar who focuses on how people work in and around policies that are unjust and ineffective in different substantive areas, such as child welfare, prostitution, child care policy, and drug decriminalization. Her dual background in law and social work has certainly facilitated and informed her amazing work over the years. My apologies before I introduce Corey and have her come up front. I have to leave. I have some unexpected visitors coming to town, so I have to leave tonight's event, but you all are in capable hands. I've heard these speakers before, in fact, just recently at an event that Nadine hosted, so I'm looking forward to hearing how it goes. So thank you and have a wonderful evening.
Thank you. Can you all hear me? Yeah. Okay. Thanks, Dean Postmus, for your kind introduction and also for honoring us by opening this event. It is my honor to stand here as the Daniel Thurs Professor of Social Justice. As Dean Postmus had shared, Daniel Thurs was a person who tried to work for social justice at all levels, at the clinical, what we call clinical and social work, so micro, meso, and macro levels. And he saw policy change as a vehicle for social justice. And he also understood that it must be aligned with the needs and concerns of people who are most impacted by the policies that he was looking to change. So it is therefore particularly appropriate to host this fall Thurs event, which is grounded in collaborative participatory research that is designed to learn from communities that were harmed by the war on drugs, and to learn from them what these harms are, and also about how to best inform the efforts and the policies that are designed to repair some of those harms. As always, I want to thank the very many people that it takes to put together these events. Aria Hayes Lawson is here. She's a CJ Fellow, LJ Mack, also CJ Doctoral Fellow, Tom Mitchell helping with all of this setup that is way more complicated than it looks, Isabel Garcia, Shantae Hatcher, Justin Hanna, and of course, our school and Dean Postmas, who is always supportive of these lectures. Natalie Flath is here. She was also integral to this research, so I'm glad that she's able to join us here. And of course, I'm grateful to Lawrence Grand Prix, who is going to be sharing with us for the trust in the partnership that led to this research, and looking forward to hearing from him. Dr. Finnegan-Carr is going to introduce him officially, but wanted to share my thanks. I also want to thank Dr. Finnegan-Carr, who I'm introducing right now, friend, colleague, and her background is in, also she is public health in addition to the social work background, and she is inaugural executive director of the UMB Center for Violence Prevention. And she's also commissioner on Baltimore City Office of Equity and Civil Rights. And we are very grateful to you to have you both reading with your critical and informed eyes, and to be sharing with us and facilitating this conversation. So thank you, and I now leave it to you.
Thank you, Glenn. I don't set a timer, then I'm going to talk over Lawrence's time, and then you won't be happy. All right. So, hello again. I am Nadine Finnegan-Carr. I'm a prevention scientist, and that basically means that I take a different approach than others. I look at how we can prevent everything as opposed to let's just fix it. From, like there are a lot of researchers that go in fixing without realizing there's stuff more upstream. And so that's kind of what I do. In the public health social work background helps. Corey already mentioned that I'm the inaugural director of the UMB Center for Violence Prevention. And I just wanted to give you all a brief overview of what the center is, what we entail, and how we came about. So what we are is the center seeks to bridge activities of those across the University of Maryland, Baltimore, and shock trauma. It is a unique endeavor in that there is no other center that works across all 7 schools and involves the University of Maryland Shock Trauma Center. And what we're trying to do is to do this not just in namesake, but also in a communities, in the community, with the community, and for the community. Our aim is to work in an interdisciplinary collaborative fashion to conduct community-based participatory action research, provide creative and impactful education to students and those looking for continuing education, and also to inform and advocate for policies that strengthen our communities to prevent violence and trauma. Our overarching mission has been to build resilient and equitable communities for all through the prevention and intervention of all forms of violence and trauma. Our focus area is Baltimore primarily, but the state of Maryland is our potential impact area. And I should also note that we started May 1st of 2023. So this is a brand new endeavor. Our true aim is to make a difference and to step up to support communities in a way that UMB has not been doing up until this point. When I think about what we are doing, what we are really doing is addressing violence, trauma in the communities that need us first and foremost. And so over the course of our time together this afternoon, evening, as we hear from Lawrence and then I am in discussion with him, what I really want us to understand is that our country needs to do better. Our state needs to do better, and our city needs to do better. And the work that we have to do is going to be different because our history here is literally rooted in trauma.
And this has impacted our culture and our identity as a country, from chattel slavery to the forced relocation of First Nations people. Our political economy is built on disenfranchisement of those who are not white. And so the system of white supremacy has really developed mechanisms which operate to maintain that social order. And that includes systematic and structural institutions, even like the university, which support that aim. White society has ownership and political power over the capital that is needed for the likelihood of most people on this planet, not just in this country, to succeed. And so when we are talking, and I know Lawrence is going to get into this, but when we're talking about decriminalization, we're not just talking about changing laws. We are talking about reinvesting, re-empowering, and redistributing something that has been entrenched in our society due to white supremacy in this country. And so what we have been living through is the effects of multiple traumas that need to be addressed. And so typically when we speak about an individual who is experiencing multiple traumas, we refer to them as being polyvictimized, right? In public health and social work, we think of polyvictimization, we talk about experiencing comorbidities. But when I think about the overlapping traumas, collective trauma, pandemic trauma, racial trauma, institutional trauma, relational trauma, educational trauma that Black and brown people in the United States have experienced, that overlapping trauma occurs at the collective and the population level. And so the best term for that is syndemic. And a syndemic or a synergistic epidemic is a term that is actually used in epidemiology to describe concurrent or sequential epidemics or disease clusters. And we're really trying to move away from disease, but in this case, the term fits because the disease clusters are those that can be socially imposed or structural in nature. They can be sociocultural as well as operate on the individual level, but they come from the structures. And so when we think about this in this way, what we are experiencing as Black people is a syndemic of injustice, which is a systematic confluence of multiple traumas on people that are based on structural and systemic discrimination and based in anti-Black racism. And so I'm actually going to stop there. I just wanted to give you the like ground that we're walking on when we say that there needs to be decriminalization and where we're coming from, and how that relates to more than just saying change the law. So with that, I'm going to introduce Lawrence Grand Prix up here. This is to tell you how tired I am. I apologize, Lawrence. Lawrence Grand Prix, who is the Director of Research for Leaders of a Beautiful Struggle. His focuses include drug policy, criminal justice, police accountability, community-based economic and educational development. He is the co-author of the Black Book and has been featured in The Guardian, The Baltimore Sun, Time Magazine, and the Black Agenda Report. And with that being said, I'm going to turn it over to Lawrence Grand Prix.
Thank you. Good evening, everybody. It's never enough time, so I'm going to try to leave some time to have some Q&A between me and Dr. Carr and bringing the folks in the audience and online. So my name is Lawrence. I'm Director of Research for LBS, Leaders of a Beautiful Struggle. We're a grassroots think tank. We've been working in Baltimore for over 13 years. Most of us were born and raised in Baltimore, went to school in Baltimore. Many of us did high school and college debate, coach high school and college debate. And when we say we're a think tank, we're not a nonprofit. We made a very intentional decision to not be a nonprofit based upon conversations with elders about the political limitations of nonprofit structure and the so-called nonprofit industrial complex. So we do a lot of work, building expertise, working with folks in community, understanding the needs of grassroots human social service providers, advocating for policies that fill those needs, and then taking that expertise and doing things like appealing for grassroots donations, but also doing things like fee-for-service consulting. We don't usually take money for political advocacy because we want to be autonomous in the way we do our advocacy and advocate what we want to do. And that's actually part of the genesis of this report. Open Society Foundation wanted to push decrim here in Maryland, Democratic trifecta. So they came to us and they said, we know that you're working on cannabis legalization. Can you work on the decrim advocacy too? And we said no. And basically it was because, we knew the cannabis stuff had money attached to it that we wanted to redistribute, so tax revenue. And we hadn't done enough research on the decrim stuff and how we actually felt about it. So actually, as opposed to taking the money to do political advocacy, they came back through Natalie at University of Maryland and said, we're going to do research on decrim in Maryland. And what they were really expecting quite explicitly was a replication of what I call the standard decriminalization narrative. And the standard narrative on decrim runs something like this. Decriminalization wastes police resources and causes overdose. We should decriminalize drugs so we can save money and then redistribute that money into services to help the community. So those are like the three pillars of the decrim standard narrative. In fact, the only question they really asked me was, what's the number? And it was very clear what the number was. The number is, if we decriminalize drugs, how much money from policing would we quote unquote save? And to me, that didn't really make any sense based upon the work that we do. So we kind of did the opposite. How this typically goes is somebody gives a research organization or university money. They go to folks in the community, bring them in, and make them an appendage of whatever research agenda the donor has. So folks do interviews, folks bring the data back to the institutionally connected researchers. They interpret the data, do a report, get academic credibility, get publication, get tenure off of the research done by folks in the community. This process was really kind of the opposite. I'm like, look, I'm pretty busy. I'm going to design the research framework. I'm going to tell you who to interview. Y'all do the interviews. I'll help you interpret the data, and then y'all write the report. Right? It'll be the report based upon not just our framework, but the framework given to us by our almost 15 years of work in the community. And so the report that we have some copies of here, come up to me afterwards if you're interested in getting one physical copy, it's online. It's basically our 2-year project to talk to folks in Black civil society. Some of them do formal addiction services, harm reduction, treatment, 12-step. Many of them are just folks in civil society who are talking about the impact of drug criminalization on community, and basically just talk as an attempt to frame those responses in the context of how does this challenge the standard narrative of decriminalization. So I'm gonna try to go line by line on that narrative and say what that means in terms of policy and what that means in terms of takeaways from practitioners of social work who might be here in the audience or online. It's never enough time. I'm gonna try not to feed myself up too much, but I do want to leave time for Q&A. So with that said, first, criminalization leads to overdose. People cycle in and out of jail, locked up on petty possession charges. This is true and important. However, when we talk to folks in the community, they understood that criminalization went far beyond the legal status of drugs. So just decriminalizing drugs did not have the impact on overall criminalization, which was perceived by many people as the criminalization of being Black and poor. So you can decriminalize drugs, but as seen in our research, when the decriminalization of cannabis happened in PG County, there was actually a net widening effect. So there was an increase in police contact through things like possession with intent to distribute charges and things like basic traffic stops. So even with the decriminalization of cannabis, you had an increase in minority contact in PG County. Similarly, decriminalization of drugs doesn't do anything in terms of child welfare surveillance and child welfare, taking away people's kids, or decriminalization and the violence that comes with housing. So you can decriminalize drugs, but it's still illegal. You break your lease if you're caught smoking in the house. So you can still be evicted. And all of these things were talked about as being ignored by the decrim advocates. So similarly, overdose is a critical issue in our city. When people talk about the violence of drug use and the pain and suffering of the loss, it was surprising. Overdose alone wasn't the core metric of what they talked about. They talked a lot about the suffering of seeing their loved ones go through chaotic substance use. So it wasn't just the physical deaths through overdose, but the social deaths and the death of the communal social bonds through the prevalence of chaotic substance use, which was the majority of the things talked about by people in our interview segments. So beyond ACEs, the cultural violence done to Black people was seen as the cause of addiction. So as opposed to individual traumatic incidences, culturally traumatic incidences to Black people, from the Middle Passage to slavery, through discrimination, Jim Crow, all of these things were put in the context of the root causes of addiction. So you could say Bruce Alexander and the social dislocation pieces of addiction, Many people in our research didn't talk about that because they said Black folks have been slaves before Bruce Alexander ever did Rat Park, right? Rat Park is a famous experiment. We could talk about it later. But you look at folks like the Black Panther Party, with Tulu Shakur and the work he did with Lincoln Detox in New York. These are culturally salient theories of the violence of white supremacy causing addiction that was more central to people's narration of addiction than ACEs and the public health approach. So in terms of takeaways, I'm trying to understand, for example, the perceived lack of support. Some people say it's in the Black community for people suffering from, I'll say addiction because that's what many people in the community say. It was important for folks to understand that the cultural ramifications of the larger criminalization of Black life implicated that even ability to be present for the people in their community suffering from substance use disorder. So think of something like vigils. That's a common practice of having visuals of people who suffer from overdose. I was just talking with an advocate from Minnesota who talks about you don't see a lot of Black people at those visuals. That's not because we don't care about people who overdose. That's because if we show up saying my kid was using opioids in the basement and died, they're gonna say, well, I gotta take your other kids away when you're Black. So the basic, and again, the basic of political organizing, this is a very common tool policy advocates use to push decrim and push drug policy reform, work very differently within the context of anti-Black holistic criminalization. Second point, wasted money on police prohibition will be saved and redistributed. I'm sorry, I think that point's completely ridiculous. How, and that's not a critique of the work people are trying to do. I'll talk more about the nuances later. But at a very basic level, how can a drug policy, technocratic, incrementalist reform movement succeed where a global protest movement failed? So we had 2020, defund the police, reinvest in communities. That did not happen. And it's just an important, again, not a big critique of drug policy advocates per se, but it is a conceptual distinction that people in our interview segment pointed out. It is not a waste of money that people are putting into policing. It is an investment in communal social control. The system is not broken, it's doing what it's designed to do. Just a brief example. Have anyone heard about that documentary, Telemarketers? Where the cops always call you up saying, give to the FOP? I kept seeing people being like, that's such a waste of money. How do you let them get away with that? That should be illegal. And it's like, you do understand that from the FOP's perspective, it's not a waste of money to call people saying, give money to the FOP, they're attacking the police, they're saying defund the police. That is their propaganda machine. They are making an investment in propaganda. And they found a way to not only make it revenue neutral, but revenue generating for them. But this is just a limitation in terms of our conceptual frameworks to understanding how social control works, how it's a very intentional, societal, anti-Black theory of social control. And I guess the takeaway from that is, please be careful about making declarative statements on things where you may not have genuine accumulated expertise. Because this is a point that is the backbone of every drug decrim advocacy campaign. And for someone like me, it's immediately turning me off. Because it's like, do you understand the policing budget? If police don't spend money on locking up people for possession, they're not gonna give it to me. They're gonna probably buy guns with it. They're gonna buy, I don't know what, it's not gonna go to the community without a sustained political effort. And frankly, people are saying things like, I don't see drug policy advocates doing that, right? So this is just that central core point, because we are gonna talk about political strategy and what this means for how we theorize change, how we theorize the Black community, and what that might mean for social work practitioners. Because obviously the next point is we need to have more services. However they get paid for it, gotta have more services. So many people in our interview catchment area didn't experience services as inherently liberatory. It's not gonna be a surprise to many people in the room, but they experienced them largely as an extension of social control, right? So the standard model of drug decriminalization reform does not really take this into account. There isn't an explicit commitment to community control. There's an explicit commitment to bottom-up, liberatory, institutional control of resources in that service investment. In fact, the standard model of drug policy reform is essentially an austerity model. It says we're wasting money, let's decriminalize drugs to save the money. So when people like me come back and say, hey, guess what? We demand investment. Lawmakers then come up to us and say, wait a minute, You promised me savings. Now you want an investment? That's the opposite of what you said. So in a very foundational way, this austerity frame operationalized itself against holistic investment, but very much locked in a theory of service that does not have any core commitment to a liberatory anti-racist framework. And just how people experience services in community, I do want to read one quote from the actual people we interviewed. We interviewed a cross-section of, I believe, 13 different people. So this is one of the folks who actually have experience with extensive experience providing substance use services. So they say, quote, "I worked in recovery homes, drug court programs, inpatient, outpatient, medication management clinics everywhere. Yeah, I've seen some things. Most of the treatment from my experience has been driven by whatever the outcome goals the program has, the primary outcome goals. It may stay on paper, it's healing the client, but the truth of the matter is that it's driven by money. How much time is it going to take to move through our treatment protocols so that we can prove to the state that we're meeting our goals and that we can prove we deserve more money for the university? How much money do we have to do things like take clients in the community or sing socially with the clients? How much of the creation of alternative programming is going to take away from this primary programming that we feel is more efficacious than whatever the alternative programming is? The drive, of course, is more about how do we keep our jobs? How do we keep money coming in? So I think this is just a very clear statement of the nature of how our suffering as a community has turned into a business. And just saying you're going to put more money into addressing the suffering of our communities does not stimulate inherently positive feedback, because people see people essentially hustling off of that suffering. So, one of the examples of this that's given very often is, methadone, right? So, but many people in this room will, of course, understand that methadone was designed to be very different than what it is now. It was seen as part of a larger social reform movement. It was supposed to be tied to more services. But the way in which, of course, it's been funded, the way it was deployed by Nixon very explicitly as a form of racialized social control, making people show up every day, not giving people take-home doses, making it liquid as opposed to a pill because it's harder to sell, harder to smuggle and do diversion with. The entire structure was experienced as social control, right? But I do want to propose an alternative and then understand how that alternative played out to be sure that it's very clear what I'm saying, because I think many people in this room probably agree that methadone has problems. But the analysis given in our interviews was more holistic and more structural in terms of how the politics of philanthropy, the politics of white liberalism implicate even more ostensibly anti-racist and progressive interventions, right? So just one example, as previously mentioned, Matula Shakur, Black Panther in New York, and the Young Lords, a Puerto Rican grassroots organization in New York, took over. People were coming home from Vietnam. Vietnam was, of course, the Golden Triangle, home of a lot of people smuggling heroin, trauma, Vietnam. Many people got addicted to heroin in Vietnam. Studies, of course, shows in white communities where they came home to jobs, came home to the GI Bill, came home to subsidized mortgages, came home to an investment in their social self-determination. Many people were able to eliminate their heroin addiction, white GIs coming home with no services whatsoever. Challenge to the medical model of addiction, but we'll save that for Q&A, right? Black folks coming home to intentional disinvestment, intentional starving of resources from the Nixon administration, eliminating the Model Cities program, eliminating the money going directly to cities, having it go to states instead. There was a massive experience of addiction and overdose. And grassroots advocates looked at the Lincoln Hospital and said they're not doing any services for Black and brown GI, Black and brown people suffering from opioid addiction. So they took it over. They took it over, and one of the things they read about was the value of acupuncture being done in China as a way to deal with withdrawal symptoms. So they brought in acupuncture as a way to deal with the symptoms of opioid withdrawal, but also, and this is critical, engage in a process of political socialization and political engagement with the people they brought in. And the people who talked to Matula Shakur, the people who were still alive in that movement, said it was the political socialization, the political engagement that was actually the most effective treatment methodology that they applied, not necessarily only the acupuncture. And that's important because when the Rockefeller Republicans came to basically kick them out of Lincoln, it was a lot of folks in the public health establishment being like, well, acupuncture isn't evidence-based. Well, I don't know if they're applying the best rigorous practices in terms of their sanitation and the training of the people that are doing work there. So they were basically supporting the Rockefeller Republicans in taking out the ownership and control of the Black Panthers and Young Lords over Lincoln Detox. So it's important because now, whether it's overdose prevention site in New York or other places, they'll let you do the acupuncture, but they'll take away the control and they'll take away the politics, right? So it's these sort of interventions where the use of acupuncture is often presented inherently as, you know, a recognition of the legacy of Matula Shakur and social justice, but the actual institutional control and the political engagement that was actually the most effective treatment methodology was taken out of the program, right? So in terms of understanding what this means, the cultural resources, take a step back. So in terms of what this might mean for social work practitioners, if Black people were using the cultural resources of that community to engage in liberatory service provision, would you know? Right? Matula Shakur recently passed away, recently got out of jail, was doing interviews about his treatment work. I was on those webinars. I don't know if a lot of people were. That's not a critique of people's commitment to social justice. That's a recognition that our information space is curated to present certain methodologies as auxiliary or additive or just some nice stuff that'd be good to have, as opposed to at a central core level, the political socialization that is done in those spaces does something that you can't encapsulate in a public health model. In terms of, again, connecting people to a sense of purpose in life and bringing people along. And that's, again, this is not essentially a treatment versus harm reduction conversation. This is just a methodology conversation. Because these methodologies can be applied in either framework, but this is something that has not been central to the conversation, right? So I'm going to read another quote. So in terms of service provision, the cultural frameworks through which policy is passed and services are provided are essential to understand how community interprets those services and how it sets the stage for a future support for policies and support for those services. So some of the people in our survey area were from Penn North. And obviously that's the epicenter of the Baltimore Uprising, Gilmore Holmes, Freddie Gray. So this is actually a quote of one of the folks receiving, doing the interview about their experience of what happened after Freddie Gray. And they say, quote, after Freddie Gray, the cameras came, Alicia Keys came, and they were like, we need a safe space for our kids to go. Like, they literally took over a laundromat, vacant laundromat next door, and we renovated it. And over the course of a week and a half, then the next day, the kids had a safe place to basically go, and that was it. Of course, now where is it? It doesn't exist anymore. It doesn't exist anymore. They repeat that statement. Those people who came in, one more time, said they cared about us. They said we're going to help us. And then disappeared again. You know what that does to people? If you talk about the history of this part of Baltimore, that is, it's essentially that people who say they give a shit come and then disappear. So this is really important. Besides just the emotionally evocative phrasing they're using, is a culturally specific frame, I believe, of interpreting politics and interpreting the morality of people providing services. Because within that traditional linear Eurocentric framework, people did some services, maybe the grant ran out, services stopped. But people say, hey, it's better than no services at all. People should be grateful. But within this interpretive framework, the provision of services was a stated commitment that was then violated. So the actual provision of services created a cultural expectation that it wasn't tied to just a moment of popularity or visibility or grant, but a genuine commitment to community. So if those services are then taken away, that creates a sort of cynicism and a framework for frustration and anger that actually makes it harder to do more policy and get support for policy in the future. So one way I've been framing it is a distinction between like a linear view of time and a cyclical view of time. So this is a framework that the quote is a cyclical framework. They keep coming in, they keep claiming they're going to do something, then nothing happens. So when you come back with drug decriminalization, when you come back with OPS and say, this time we promise you, we're going to bring you services. This is how we promise you there's going to be wraparound investment. We promise you there's going to be economic investment. People are rightfully very skeptical, and not just skeptical, they perceive it as a violation based upon their previous experiences, right? So it isn't just imperfect. It is a cultural pattern of neglect that is framed culturally within a cyclical view of time as opposed to a linear progressive view of time, right? And this really gets to a very important understanding about political theory and how we can hopefully wrap up. So the standard narrative of drug decriminalization comes from a particular view of politics, which is, we get it, social justice is good, but policymakers only care about hard numbers. We're going to have pragmatic, evidence-based public health approaches with very powerful institutions backing us to give those policymakers cover to pass these bills, right? And this is a very prevalent view. This is the only pragmatic policy that can pass, right? So an anti-racist framework will have a criticism of this political theory. So Derek Bell, founder of critical race theory, along with Kimberly Crenshaw, presents this theory of interest convergence, which is oftentimes misinterpreted. But it basically says that the advances made policy-wise by Black people in the 20th century did not solely come to the recognition of the moral obligation of powerful people. It came because they had an interest in the particular concessions they gave. And this is often misinterpreted as there's nothing we can do. That's not what he says. It's saying if you see policy advancing, understand the interests that are converging and have an analysis of those interests, and do organizing to present different interests to force them to converge with your interests. So the standard narrative of drug policy occurs within the context of the Great Recession, declining state revenue. It comes from the session of Michelle Alexander, the new Jim Crow, mass incarceration framed to nonviolent drug offenders. So I, amongst others, argue that essentially it's building an interest convergence between states with declining state revenue, not wanting to invest in prisons, and having over-incarcerated low-level drug offenders. And it is an attempt to utilize that interest convergence between fiscal conservatism and over-incarceration, not in terms of a social justice argument alone, but also in terms of recognizing the social disruption that comes from incarcerating hundreds of thousands of people. You know, you're creating conditions that are making it hard for communities to stabilize, and that's just generally bad. So if you actually understand the limitations of its interest convergence, we begin to see the need for a new theory of how to advance policy. So for example, the Justice Reinvestment Act. Justice Reinvestment Act passed in over 30 countries, states in America. It essentially argues that we're going to change sentencing around low-level drug offenders, get them out of jail, use those savings to no longer incarcerating those people, and invest those savings in community. So this is actually from Justice Reinvestment Winding Back Imprisonment from Brown et al. Over 30 states passed justice reinvestment policies. How many of those states, in your brain, how many of those states actually invested upstream in community programming that's preventative of incarceration? Of that 30. The answer is 0. That does not mean there is no investment at all. But the vast majority of the investment occurred back into the criminal legal system, into pretrial services, into parole and probation. That was not what was promised. I mean, in social workers, into folks, you know, like the folks in this room. So that's important to understand, because this is the takeaway. When you are in front of a client, you are not only you as a human being, you are a manifestation of the larger political dynamics that produced your ability to be in that position of power. Another way, it's like all the suffering and all the pain that politicians claim to care about Black folks see that invested in things like social work and they get very frustrated because they were promised and they understand the need for a much more holistic intervention and the conditions that produce their oppression, and what they have is you, right? So in that moment, you aren't just a person, you are a manifestation of a system that's failed them, right? So this also produces really problematic political alliances in terms of adhering only to interest convergence to get these bills passed. So just from the EPA conference, drug policy conference in Arizona a few weeks ago, decriminalization is passed in Oregon, it's passed in Portugal. There is, over the past couple of years, a severe backlash to decriminalization. People were promised overdoses going down, overdoses have gone up. Drug policy advocates defend that it's fentanyl, but people in the community are seeing more visible homelessness, more visible homeless people suffering from substance use issues. They're blaming decriminalization. At the drug policy conference, on the panel about how we deal with the backlash, the stated advice was, explain to people that this is a product of a propaganda campaign to obfuscate the success of drug policy reforms, and that they're distracting you from the real threat to public safety, which is people carrying illegal guns. So that's important, because in our work at LBS, we constantly push back against people trying to put mandatory minimums on the mere possession of illegal guns. People who use drugs sometimes sell drugs. When you're selling drugs, you have no way to protect yourself because courts will not support you because your commerce is illegal. Many people carry guns not because they're drivers of violence, but because they have to protect themselves. So that's a prime example of one of the core takeaways in our study. Many people were saying, how can we trust that this investment in harm reduction and decrim will actually be anti-racist, when many of the institutions presenting these policies are institutions implicated in the reproduction of racist policies in our communities. So you're looking at the gentrification produced by institutions like Johns Hopkins. You're looking at the stop and frisk policies of folks like Michael Bloomberg. And of course, the Bloomberg Foundation is one of the biggest funders of harm reduction. When you see things like DPA saying that the way you get political support for decrim is focusing on people with illegal guns, it triggers all the concerns people in the community have about the inability of this interest convergence actually to produce genuinely liberatory policy. So at LBS, and don't have nearly enough time to go through this as much as I want to do, we have presented an alternative theory of how to pass policy. So it is difficult in a society framed through anti-Blackness to believe that working class and middle class Black folks have political power to push policies of their own design. However, in the Black community, there's a bevy of people with political interest in things like economic development, in things like service provision, in things they control. It is a policy to invest in mobilizing those folks in a support of building out a treatment and community investment infrastructure that will actually create the conditions to make things like decriminalization possible. One of the biggest things they're saying now in Oregon is that they waited until after they passed decrim to build out the treatment infrastructure. What if you flipped it? What if you went to the people who studied under the Tulish Report? What if you went to the community organizations and said, we're going to invest in you, and then we're going to use that investment to build the political will to push a decriminalization policy? So these are the sort of things that we've been used to frame our work around reparations. So obviously cannabis passed, you tax legal cannabis sales. We've done the work over the past 8 years, again, without foundation support, without any grants, because they weren't funding this, to build a theory of local control over those cannabis dollars. So it's not going to be in Annapolis. That money is going to go to localities, Baltimore City, PG County. Based upon the amount of cannabis arrests those communities produce over a 10-year period. So the idea is that through local control, individuals and community have much more proximate impact and power over their city council people compared to their state senators and the governor. This is not any inherent belief in the liberatory power of city council or county councils. It is merely a political theory that putting power closest to people creates the possibility for self-determination. Reparations is not just giving people money. It is the people who were aggrieved by a harm, getting to choose for themselves what they believe is reparative of that harm. So that's not only an example of what we think is good policy morally, it's also good policy politically. Because the people who are perceived as the biggest impediment to drug decriminalization are the community associations, are the Black churches who have a lot of interest in their local communities. in their city councils, in investment in their communities. If you tie decriminalization to intentional investments with those communities, you create the political coalition for something the technocratic interest convergence model cannot produce. More broad-based investments in actually addressing the conditions that drive addiction, that drive incarceration. That is not a recognition of harm reduction and things of that nature, public health being inherently bad. It's a recognition of reality. I've done the math. There are about 20,000 folks apparently in Baltimore City with substance use disorder, opioid use disorder. On point, the overdose prevention site, the safe consumption facility in Harlem, services about 200 people a day. Let's be generous. Let's say they can serve 300 people a day. How many overdose prevention facilities do we need in Baltimore to not have all, but the majority of those people who use opioids daily have their doses supervised? The number I think is 34. Politically, is anyone in this one think we're going to get 4 of those? When only 2 of those exist in the entire country? That's not a critique of saying I don't want them. I do want them. It's because I want them, I'm so adamant that we have to conceptually, politically shift the way we think about drug policy. So if you're going around talking about people with illegal guns and building coalitions with them, but find it impossible to build political coalitions with the treatment community or the community associations, that is not going to play. That's not going to work in a state with the biggest Black caucus. So what we get told is that this is Pollyanna. We will be nice if it's possible. The opposite is true. The only way we get these bills passed is if we go head on into the perceived backlash, find the actual interest between our community, and leverage those against the powers that want to keep the status quo essentially intact. So I have more to say, but I think now we have time to do it. Yeah, so that's about what I want to hit. 45.
All right. So even though I've read the report or spoken to you, I guess we should use these. Can you guys hear us on Zoom? Can I just get a, oh, I guess I can't get a thumbs up because I can't see.
I don't know if they can see the response.
Yeah, we can see Q&A.
Okay.
Okay,
Yeah.
perfect. All right, so like I was saying, even though I have read the report, we've had conversations, your op-ed and everything, I still was like, you know, the pen is furious as you're talking, as usual. But I want to start with the undergirding everything, right? The white supremacy leading to different forms of violence, which results in addiction as a trauma response, right? And in the report, when you talk about all of that, you mentioned the need to decriminalize Blackness.
Mm-hmm.
What does it mean to decriminalize Blackness in this context?
Yeah. So it's a decriminalization of Black sovereignty and a recognition of Black people's right to control the institutions in their communities that govern their lives. And so it's different than merely not applying the policing power to Blackness. So that's a negative view of freedom. Mm-hmm. So when I'm saying decriminalize Blackness, there should be a positive view of freedom and investing Black folks with the resources they need to self-determine their own futures. Right, because we get a lot of folks who, again, are willing to say, don't lock them up for drug possession. Mm-hmm. But we aren't seeing the systemic political support for investments in communities that are actually controlled by communities. Right, and I think that there is a real belief that even amongst the well-meaning philanthropic establishment, mm-hmm. that me and my people have done the research, many of them are Black and brown, we know what's best. Folks in community have good intentions, but they're traumatized. They don't have access to academic resources. They don't have access to best practice throughout the world. They just don't know what's best. So they need to trust me to design for them what is best for them. That's not a statement that's articulated much these days. It's very difficult to not see that as the operative methodology of how most institutions operate.
Oh, I was like, I'll get a Teamster instead of like, just like.
Got it.
Right, and so decriminalizing Blackness recognizes that form of, you know, I call it like anti-racist racism. Mm-hmm. where it's like black people deserve the best practices, and anyone who doesn't want them is an enemy to black people, especially black people who demand the freedom to do what they think is best. That's a form of criminalization. That's a form of violence and policing that gets sold towards liberation. And like, isn't to say that everything, foundations are not always bad. That's not my argument. That especially in Maryland, slave state, in a country that makes it very difficult to conceptually believe that black people had the ability to produce for themselves high levels of scholarship, high levels of rigorous practice and theories that meet their needs. It's very easy for well-meaning people, the people in this room, to fall into that trap, which is why we talk so explicitly about it, because it is, I think, the most dangerous trap for the rising new wave of socially conscious people that want to make a difference, but end up replicating the systems that are criminalizing blackness.
Okay. So I hear that. And when I hear that, I really do, because that takes us back to some of what you even say in here, right? That as a part of that, thinking about the survival culture that is involved in selling drugs, that it's more than just I am selling drugs, I am selling addiction, but that it is a part of the survival culture that's in response to being criminalized, right? So if I can't hold down the job, my education system hasn't worked out, and this is the only alternative to me, this is literally an economy that we are feeding into. And that takes me back at the beginning. I mentioned, the syndemic of injustice and how that is rooted in anti-Black racism, just like criminalizing Blackness is rooted in anti-Black violence and racism. And so when we think about how we're going to address this and how we're going to approach this, and recognizing that it has to be more than, our favorite person says, community informed, instead of, community based and community placed, in order for it to work. How do we ensure that we work with, the treatment agencies, as well as those who are being treated for addiction in the current society?
So, and to go back to my previous statement, even people like me, so I'm going to implicate myself, I have a hard time truly sometimes believing that the theoretical frameworks that I've been presented to things like scholars of African-centered culture, that these are actually rigorous, empirically testable, theoretically valid frameworks to build out entire treatment ecosystems. So just one example, he's now deceased, but Amos Wilson was a professor at the University of New York. He talked a lot about African-centered culture and approaches to violence. And one of the things he says is that violence is the externalization of a suicidal impulse. So in a society designed to inculcate anti-Black concepts, anti-Black theories, it's very easy for young Black men to internalize notions that other young Black men are not valuable and therefore it's okay to shoot and kill. So to me, it's like, okay, that's some cool stuff to think about. That's some cool stuff to theorize. It makes sense. I'll use it. But then I thought a data point that really shocked me. If you actually look at the ratio of suicides to homicides amongst white people, it's 3 suicides for every homicide. For Black people, it's 3 homicides for every suicide. It's an exact inversion. So that's empirical validation, at least, beginning to see empirical validation of that conceptual concept. And that's when I realized, wow, it's like, no, it really is externalization of a suicidal impulse. So extending upon that, I think many people in our community see overdose and chaotic substance use as the internalization of a suicidal impulse. Where if they see themselves as Black people not valuable, not able to contribute to the world, it's like, I'll just drop out of society. I'll enter into chaotic addiction, and at least I won't be feeding this system I know is violent, doing violence in my community. So those conceptual frameworks and people building service interventions on those theories have the ability to really intervene deeply with a different theory of the problem than, again, the pure public health disease model of addiction. Than even Bruce Alexander's vocation thesis, which is not culturally specific. The problem is if those things do work, the people who have the best ability to operationalize those theories aren't at Johns Hopkins, right? Aren't at Bloomberg, aren't at Able. And if they're the ones who actually have the best practices, a lot of those people go out of business. But there's a political economy behind this service provision reality that requires a political intervention into the forcing those resources and forcing that study, forcing the academic resources, and actually studying these things to build out more fleshed out theories that can justify more local communication.
Yeah. I mean, and there's a similar quote in here too, right? Like the substances will be there for me when the community is not, when the people are not, when the treatment is not, when I don't have whatever I have, I still have the substances. And that's the only thing that I can depend on. And so as a result, this is what happens, right? So I get that. The other the one of the other quotes that really, there's so many in here. But there's one that really stood out to me, and you kind of said something similar in your talk. And the direct quote from a participant was, how can we expect the same people who created the torture to fund our recovery? You know, and when you were saying that we are putting more money into the suffering in our communities, that is exactly what we are doing when we don't utilize the lens of the people and we come in with we are the experts, we know best. We know you best, even though you haven't walked a mile in my shoes. You know, we know what you need. Just take this methadone, go home to the hovel that we allow you to live in. And just, you know, come back tomorrow for tomorrow's dose. Like, that's it. And when you think about how do we redistribute funds via decriminalization without understanding that that's what we're doing, that's why it's not working.
Yeah, and similarly, like you said, people don't have any hope that the larger conditions will change. And in many ways, the standard model of decriminalization, it's like, yeah, we can't do housing. We can't do broad-based economic investment. We can do decriminalization, this technocratic fix, and that's all you can expect.
Right.
So people are going to respond with that sense of frustration. And it's one of those things where it's not that it can't be done. It's that the people who have been empowered to lead on drug policy, they can't do it. Because it requires a mobilization. Because I don't want to go too deep into the politics of it, but it's infuriating, quite frankly, where people are telling us that they are master political operatives. And in a state with a Democratic trifecta and one of the highest overdose rates in the country, we can't get paraphernalia decriminalized in the state of Maryland. Something is wrong in terms of the theoretical framework of how we do advocacy. And I think a big part of it is they want to move people who are moderates, who might otherwise backlash on a policy, to get them to chill. What I'm proposing is drug policy still in that framework, very, very low on people's voting criteria. Those people are not mobilized to vote on drug policy affirmatively. They are trying to stop them from being aggravated by really a fear of crime.
So and that's where I was going to go with.
Yeah, that's their entire advocacy strategy. If diffuse the fear of crime that could backlash against their relatively technocratic drug policy reforms. What I'm saying is mobilize the constituency. Their number one issue is getting money in their community. And you turn them from being people who are attacking drug policy reform to people who are leading on it. That's how they get the resources. They're the number one issue. That's a different theory of political mobilization that actually brings in people who have the ability to potentially swing a primary in some of these state representative districts.
But you can kind of see where they're coming from, right? Like the number of homicides we have, the number of violent crimes that are going up in this city, in this state, trying to prevent that. But if you still don't think about it from the community's perspective, the only way to address all of these ills is to work with the people that are most impacted. And, you know, if we're thinking about the fact that I've undergone trauma and I'm living in poverty, then my response is from a place of trauma, and because I need to survive. Whether it's substances, whether it's committing crimes, that they all have the same thing. So it's very interesting that the nonprofit industrial complex is currently funding the types of things that will deal with certain people who are committing certain crimes, but not addressing the underlying issues, which are the same.
Exactly. Yeah. So the theory is that we're going to trade off a more perfect victim, the substance use disorder person, for the quote unquote violent criminal.
Right.
Right. So we're going to mobilize the machinery of policy against the bad guy with the gun to get them off the back of the person who's down bad using substances. Right. Now, for many reasons, that's very problematic. As previously stated, like John Paff from, oh my gosh, I think he's at Hunter. He's at one of those New York schools.
He's in New York.
Yeah, so he wrote Locked In, who basically was a corrective to Michelle Alexander's analysis, which may have been true with the federal system a few years ago. The vast majority of people locked up are not locked up for nonviolent drug offenses. Not anymore. They're locked up with extremely long sentences for relatively minor violent crimes, second-degree assault, illegal gun possession, things like that. So framing, progressive policy of just not locking up people who are holding drugs is like literally the least you can do, and all the juice has been squeezed out of that. But it's just politically more terrifying for people to actually think about violence. Like, people are so separated from the conditions that produce violence, it's easy to project pathology onto anyone who gets into a fight or anyone that carries a gun when no one around you is experiencing that life. I mean, I remember thinking about talking to people who work with people who are coming out of jail, and it's like, look, if your family can't keep the lights on, what kind of person are you if you don't do the one thing that you can do to help keep your family's lights on? Yeah. And so, as opposed to pathologizing that spirit of care and also pathologizing that spirit of resistance, there are some people who are trying to redirect that impulse into a theory of providing services that affirms people's agency.
But whose agency?
An agency towards what, right? So, there's a lot of talk about, I was in New Jersey, and Newark, New Jersey has cut their murder rate in half. It's a black-run city. The son of Mary Baraka, famous poet, black Marxist, black socialist, black nationalist, Ross Baraka, the mayor, cut the murder rate in half. Have folks heard about that? And one thing, talking to the violence prevention people there, it's like, we are against violence done in our community. We're not inherently nonviolent people. We believe we should destroy the systems that are oppressing us. And that makes a lot of sense to me. But the problem is, if you build programming from that methodology, who is that going to turn against? It might get turned against the gentrifiers. It might get turned against, the people that run a lot of the nonprofits in the city. That work was being done for the Nation of Islam. That work was being done in a black-controlled, autonomous container. And that was able to produce a result that has empirically been proven as effective, but cannot be easily replicated by a nonprofit industrial company.
But the narrative that comes from that is that Baraka has brought in a bunch of thugs to clean up the city of Newark, as opposed to the fact that he is working with Black-led institutions to work with people who are most impacted to address the issue of crime and violence, and substances, actually, because their substance use rate is down too.
And similarly, the people working on violence prevention are leading on the drug decriminalization and Narcan distribution effort in Newark, New Jersey.
Right.
And yeah, it is very easy to pathologize folks who actually are from grassroots when they do any services. And there's this weird cycle that happens that if you do have someone who, some money gets misallocated, some person goes to jail, there's a call to like, oh, we must have more accounting, we must have more regulation, we must have more oversight. That makes it even harder for grassroots service providers to get access to the money needed to do violence prevention or harm reduction treatment work. So there's this vicious cycle of policing in the nonprofit space. The demand for audited financial statements, the demand for years and years and years of proven standing to get access to public money. These are also tools that are really sort of a colorblind racism that locks in certain powerful large nonprofits as the only safe place to put public money. So that's why we're doing things like the reparations fund. We're doing things like demanding opioid settlement money just going to come down the pipe very soon in Baltimore City, be open to investment in building the capacity of small grassroots nonprofits to actually do services and get access to this fund.
So I have one last question and then we'll turn it over for audience questions. So you mentioned Portland, you mentioned, you mentioned Oregon, and you mentioned Portugal. And, I was recently in Portland and I can see, like visibly see the reason why people are like, well, now we have this like druggy, homeless thing taking over our city, which is interesting that that's the way it's visualizing, when part of what the issue is that similarly to some areas of Baltimore, but Baltimore is smaller, so you don't see it as much. What really has happened is that when COVID hit at the same time, a lot of people moved to remote work. There are a lot of buildings in downtown Portland that are completely unoccupied by businesses because people are at permanent remote work. And then you couple that with the probably same amount of homeless people that would have been there, who now are in, squatting in those buildings and squatting in those areas. So visually, it may look like that, right? And so you mentioned that it would make sense to put the grassroots addiction services first before the decrim, which is not what they did, because now what's happening is nonprofits, people who are in the grassroots addiction space are trying to put up and do this work. They're also trying to do it downtown where people are, in buildings where the landlords are trying to get full market value from basic, not basic, but, grassroots treatment providers who can't afford full market value. So you have this like perfect storm of how do you provide those services. So if we don't want to end up the way Portland is, and we want to put our services first and figure out what that is, besides making sure that we train more of them, what does it really look like to implement this in a way that is effective, so that in the long run, decriminalization here in Baltimore doesn't look like it does there?
Yeah, and that's one of those things where there should be entire meetings, tables dedicated to answering that question. Like, Donald Trump can't answer it in 2 minutes. I'm not even the person that should be answering it for real. I'm just a policy wonk that knows where the money be and know we gotta get it. It is complex in terms of like what is reimbursable through Medicaid. What types of money do we? Sometimes public money is very difficult in terms of reporting requirements. And how do you build capacity of grassroots organizations to get the insurance and all the accounting necessary? So there needs to be a rigorous study, especially for people who consider themselves progressives, around the mechanics, the science and art of how we actually build institutions with public money. Because right now, again, when the crisis happens, they say we got to build out the infrastructure. Well, who can do that? The already existing multi-million-dollar nonprofits, the already existing big treatment providers. And that's the exact opposite of what we do. So before the crisis comes, we have to really take an analysis of the landscape. What are the types of things we want to see? If we want culturally diverse services, who's providing those? What are they providing? Why can't they do more? Well, again, what is insurance not reimbursing? What do we need to do to fill in those gaps? And how do you give those folks capacity before the crisis hits, before the new version of fentanyl or carfentanil or dilidine creates the drug hysteria around the zombie drugs tomorrow, right? These things are coming. And there's such an impulse in the crisis to fall back on what can we do now? And that always forestalls the deeper work of why the person you're turning to, how do they get that capacity to do the thousands of treatment beds now? It's because they had access to resources that working class Black and brown people are denied, and the violence done to them to make sure they never had those resources, right? So it's not just investment, it's investing in the capacity of grassroots service providers to actually be autonomous and actually have a chance to scale up.
All right. I think we might have some questions.
20
No?
minutes.
Oh,
20
we don't have
minutes
any questions there?
No.
Any?
Sure,
Okay,
we
so
have questions online.
then let's go. I just want to double check online because sometimes we forget them
Yeah.
first. So I'll turn it over to questions from here in the audience. And then those of you online, if you are so inclined, please drop some questions into the Q&A section of the Zoom. So, turning to you, my audience. Otherwise, I will just keep talking. Yes.
What message would you like our social work students to have? What would you like us as faculty and as social workers to tell each other? I know you said a lot.
Yeah.
What would you like to see us doing in the classroom?
Yeah. So a few things briefly. Many people in this room, I believe, got into social work to not be an appendage of the custodial system, even though it's how a lot of people experience social work, unfortunately, right? So I guess my point is, if you want that to not be the case, good intentions, DEI training, implicit bias alone is not going to be enough. There's a reason why people experience social workers that way, is that in many cases, the investment done for them is an investment in social control of a different kind. So Derek Bell calls it forced fortuity. So as opposed to interest convergence, we have to force conditions where fortuitous things happen for our community. So a big part of this talk is that if you want to have more space to have more things in your community that are doing things like job training and housing, the things you know work, those things are not going to exist. In fact, they're going to keep funding you to not give those things because they know they can sell that, and they don't want to do the larger, more difficult work of funding things upstream. That's Justice Reinvestment Act. That's entire history. So in addition to engaging in a rigorous study of the science and art of how public money flows, do a rigorous study of the Black civil society institutions and the communities within which your people are living and being served. Because there's probably much more there that you could connect people to than you know about, right? Is the reality of the social media algorithm, the corporate media algorithm, and just life is hard and people are busy. There's so much happening in every city in America that we just don't know what's happening, but especially working class Black people. So there's probably more there that is being able to help your clients than you know about. So taking seriously a call to rigorously study what people are doing, not assuming all churches don't want anything to do with drug addicts, not assuming all drug programs, all job training programs are going to keep people out there on methadone. But actually being willing to do the work to understand and engage and navigate that space. That's also how you're going to connect to people who are doing forms of advocacy that are going to create the conditions where your experience of social work is more aligned to what you want it to be. And it's not to mean that those things are perfect. Like, for example, construction jobs. Like, construction jobs have traditionally been a great source of work for working class Black folks. They also produce a lot of pain, potentially drive addiction, and for many good reasons, they drug test people. They don't want people operating heavy machinery. I'm not saying this is easy and that what we gotta do is snap our fingers and stuff will be better. But it's the type of work. It's the type of seasoning and and work that's going to be needed to change the conditions in which your clients are living.
I would add to that, that especially your students, our students, recognize that Baltimore City is a part of your textbook. Do not just think of it in terms of what Professor Greif, what Professor Shadema, is providing in the classroom, and watch the local news, maybe not certain news stations, but watch the local news, read the local newspapers, and see how they are portraying the people that you are planning on working with. And also read between the lines as you do so. Don't take it at face value, but get to know Baltimore, get to know the real people that are impacted by the work. When you are doing your field placements, when you are in the community, don't look at it in terms of another thing to check off, but recognize that these are living, breathing human beings who are impacted by so many other forces, and you are there especially for the clinical crowd, you're there doing individual level, but there's a macro level that you should be aware of, even if macro is not your focus. So I would also add that for the students. Good question. Oh, I saw a question behind.
I will.
Go ahead.
So, Dr. Kaminga, you opened up with sort of examining the how, and you spoke about empirical, rigorous studies. I'm curious what the research should look like. What is the how of the research? What are the methodologies of the research? As you talked about, sort of doing a community-based, participatory research, but how does that incorporate sort of that interdisciplinary and those practices, so we don't get in front of folks sort of perpetuating the trauma and the harm? And also, how do we connect that to policy? What does research?
Yeah. There's I'll just speak on it from my perspective. So we come out of a particular experience of African-centered culture, and that links to a lot of more mainstream dominant research frameworks, and I think very interesting and important ways. So again, something like Bruce Alexander Rat Park, right? So for people who don't know, you take a bunch of rats, you isolate them, you give them water with an opioid and clean the water. They'll take the water with the opioid. Put them in a condition where they have food and ability to have companionship and sex and enrichment. Even when you provide them with water with drugs in it, they don't become addicted. They stick with the regular water. So that to me is just, empirical validation, whatever. That's an example of a traditional research methodology that I think has important implications for Black people, because there's no equivalent of that part for Black folks. So we've never seen the counterfactual of what if we actually had a fully resourced community, what would that mean for addiction? So, but granted that, I think it's important to listen to how people actually narrate the complexity of how they experience their conditions and learn how to interpret what they say. Like, I can't stress this enough. We as working class Black folks know the scripts to say what we think people want us to say. So much qualitative research is frankly garbage, because we're just regurgitating our script, especially if we don't trust you. And even when we do tell our truth, people don't always have the interpretive frameworks to understand what we're saying. So that's one of the things that I say about, like, to wrap up. Methadone, Suboxone, important in stopping overdose. As I previously said, overdose, not overdosing is not the definition Black folks have of flourishing. But similarly, it's like within the research methodology, if you're just in your room taking your methadone or Suboxone and not overdosing, you are a success story. From a Black communal perspective, that is a failure. Not because we don't want people to live, but because you are not engaging and flourishing and being productive in community together, right? So that, again, oftentimes gets interpreted as, oh, so you just love 12 stuff, you hate harm reduction. No, I'm saying that if the community is telling you what they define success as seeing people who are engaged, who are serving the community, however the community defines that, listen to that. And you can incorporate that with Suboxone. You can incorporate that with methadone or 12 stuff, right? So I think it's important to not fall into the disciplinary wars that divide things in the academy or divide things in how people have experienced these things historically, but listen to what people are actually saying, because you're going to find more there than I think many times your textbooks or people's simplistic narrations would tell you is there.
And I think that goes for all research, not just decrim, not just violence prevention, right? Like, Black people don't trust us. Social work, public health, all of our institutions are complicit in what has happened to them. We are complicit in the torture of the community. And so they don't trust us. So that regurgitation of talking points that you get in qualitative research and quantitative research, because we know what, we can go through a survey and answer it the way you want. You want to ask me who was the first president of the United States, I'm going to say George Washington, right? Like, I'm going to give you what you want when you want it, just to get you off my face. And that happens with, I've seen it with cancer research. Like, I've seen people hold focus groups with Black men who have prostate cancer. And those Black men with prostate cancer will say, yes, this worked. Yes, I like this doctor. And they won't come out and tell what really happened. Half the time, because the researcher or the person conducting the focus group looks like you, Natalie, right? Like they're gonna send you're gonna send a young white female in to conduct research on Black men with prostate cancer. Tell me how that's gonna work. But it's the same thing. Like we do the same thing with them that we do with drugs, with violence. We don't think in terms of how is our methodology in conducting this research even effective or feasible.
So to briefly follow up, social work folks, the work you do, engaging those Black civil society containers to figure out what's available, it's also the work that's gonna help you build the trust to do the forms of research to get beyond that. So like, for example, for our report, Natalie did the interviews, but I did pre-interviews where I'm like, look, Natalie's gonna call you, but treat her like it's me. And like all that stuff you normally don't say in front of white folks, say it to her, because I need you to say it, right? And so that's kind of how we got the quotes we got, because we weren't gonna get those without, again, our 13+ year working community, but also a very explicit acknowledgement. It's like, don't treat this like just a regular interview. Like, say the stuff that you would normally say if you and I were just talking, because then we're going to use that to push things politically. It's going to push that perspective forward. The problem is they say it's just us. They say, we know y'all be on that Black stuff, whatever. Right? It's like, we didn't get this from nowhere. Like, we got this from 15 years of people telling us this, but they don't say it in front of you.
All right, so we have a couple of questions from the audience, and then yes, that's easy, and we're running out of time, so I'm trying to think which ones of these will at least get us a different answer that you have. So one is, this is an interesting one. How can, if we were to go to this, universal health care coverage, you talked about public money, and how could universal health care coverage, taking the profit motive out of our current insurance system, how would that positively impact to provide non-racist decriminalization of substances?
I mean, it would help. What many people, and I'm playing with how to explain this, for some people, for better and in many ways for worse, the for-profit system was basically their drug dealer for a long period of time. And some people would say that that's pill mills, that's driving addiction, but it was also a form of safe supply. Right, so we unfortunately have this complex relationship with our current for-profit system, where it was a mechanism of some forms of safe supply, but was driven by profit. Now, if you have a universal healthcare system, there's obviously a lot of questions about the specifics, but I would say that it's important to understand that it would actually be, for example, the success of Portugal is of course always backstopped by the fact that they have universal healthcare. And that's never talked about when applying the Portugal model to America, right? But I think, in conclusion, the caveat I would say is that given the unique cultural, psychological legacy of white supremacy and racism, merely access to healthcare is not experienced inherently as a vista of liberation for Black folks, right? Not just medical racism, but also the over-medication of young Black youth with things like ADD medication. Right, so in some ways that medical exposure can be a vector of different forms of, over application of, for example, the diagnosis of schizophrenia in the 50s was largely given to suburban housewives. In the 60s, it turns to a diagnosis for poor Black people, specifically within the context of political turmoil. So people were saying things like, they're out to get me, they're out to get me. And they were like, you're schizophrenic. It's like, no, I just read about COINTELPRO. Right, so if you are understanding medicalization as a vector of social control, that in of itself can forestall your understanding of the more comprehensive need to, again, create containers of Black political control, even of those health services, to be able to not just address those limitations, but to produce the forms of care that actually reflect our culture and can actually respond to it.
The last question I think we can fit in the time is, for the studies, for the work that we have both been suggesting, which groups, which organizations here in the community do you think are best positioned to do this work?
So part of the problem is, like, I can name people, but I don't want that list to be comprehensive or be seen excluding people. I'm implicated in the same critique I'm presenting. I don't know all the people doing all the work, right? I can tell you people I know, but the process needs to not be dependent upon people like me knowing those people.
Right.
It needs to be dependent upon those people being able to autonomously advocate for themselves and access to resources. We know a lot of people. We know people that run halfway houses. We know people that do, 12-step. We know people who do, forms of needle exchange. There are just so many people. So I would say let's focus on containers. Let's focus on institutions that can help incubate a more comprehensive system of Black civil society. So someone like Collectively and the collective work, the work they're doing with Collective Give, so they're incubating grassroots, Black-led, small nonprofits and businesses. Like they had actually a tab on their website for like substance use providers. I don't think there was anyone there in that tab. So just even connecting like the substance use folks to a container like Collective Give. We see that OSI is shutting down. So the question is, if that is a hub of resources, however problematically they would distribute it, what's going to replace that? And how do we build like actual incubators and containers for resources that can actually build synergy between not just different people in one industry, but across industries that can coordinate investments in geographic locations across sectors. We're looking at places that were disproportionately impacted by over-policing for the investments of cannabis taxation revenue. How does that correlate with the investments from the opioid lawsuit? Who's coordinating that synergy? And is any of that controlled and operated by working class Black folks? Is any of it accountable to community? So we're going to have to build intermediaries, like actual intermediary institutions, not just fiscal sponsors, so those are good too, but actually empowered to do incubation, actually empowered to do advocacy, actually empowered to choose the direction of how resources are flowing, not just pass them through. So that's what it's going to take. It's going to take infrastructure, not just individual organizations.
We did hear examples of like youth development and support indigenous to like Black Baltimore communities in our interviews, and we do outline a little bit of that in the report.
Yeah, so just one example is Penn Norris. Penn Norris has a recovery center that was actually people that were trained in acupuncture from the folks at Lincoln Detox. Part of what they experienced is that the nature of the funding streams for methadone froze out their ability to do more comprehensive investment in things like acupuncture and led them more towards the medical model. Similarly, there was folks who were doing Tai Chi out of that Penn North Recovery Center. And just to wrap up, one example of what I'm saying is that we had a picture of them doing Tai Chi, but it was so pixelated we couldn't use it because we wanted to make that the cover art for the event. So again, like there is documentation of people doing this more holistic stuff, but it's literally that isn't the investment in giving people the access to see it. Sometimes it's literally not photographed or photographed well enough to be able to be reproduced for you all. So that's just one example of things that can be done, the reason why it doesn't happen, and how people are still building and doing community despite those limitations. So the question is, how do we use those seeds of that and build upon those and give institutional infrastructure to those?
And with that, I think we are pretty much done. So thank you all for your time this evening. Thank you all.
I actually report that if you all want a physical copy, it's also online at lbsbaltimore.com. So you can feel free to follow us there. But yeah, we can talk about getting a physical copy after.
Thank you both. I also want to mention Brooke Kearley and Judy who worked on the report. I want to especially thank the two of you for being here, for sharing with us, and to invite anyone. There are 77 people, by the way, who are out there in Zoom.
Oh,
so
wow.
Thanks to the 77 people who joined us and those who have questions. And there's some light fare, so please come eat with us. And if you all stay a little bit, there might be some room for conversation as well. Thank you.
Thank you.
Thank you.